And now for our final slide, or set of slides, on acyanotic heart disease. So we have an atrioventricular septal defect. So you notice that we're talking about an atrioventricular septum. So that's a septum that divides the atria from the ventricles, and there's a defect in it. So we'll talk about what's going on here. The pathophysiology, and it's also known as an AV canal if you have a complete defect. And the reason why it's called an AV canal is because the atria and ventricles are completely connected to each other. So we have an endocardial cushion defect as the pathophysiology of why you get this AV septal defect. Remember, we talked earlier about how the endocardial cushions form part of the atrial septum, part of the ventricular septum, and also form the septum and valves between the atria and ventricles. So you have an ostium primum ASD with a membranous VSD, and we'll talk about that in a minute. And we also have a failure of the AV valves to develop, and all four chambers are open to each other. So what that means is that blood flow can mix all throughout the system, but primarily since the left side is going to have more pressure than the right, blood's going to shunt from left to right. So let's see what we have here. Let's start with the body coming back. You have unoxygenated blood coming back to the right atrium, and it mixes with blood because remember, there's an ostium primum septal defect, atrial septal defect. So this mixes with the oxygenated blood from the left atrium, goes to the right ventricle, but it's regurgitant because you still have no separation between the atria and ventricle, goes to the pulmonary artery, goes to lungs, comes back, and has a left to right shunt, and also regurgitation here as well. So overall, there's a left to right shunt, but there's all kinds of mixing between the atria and ventricles, and between the atria themselves and the ventricles themselves. So you can get a lot of valvular regurgitation because the valves never developed. Commonly associated with Down syndrome. It's a very important association here. Down syndrome can cause the AV canal kind of defect. So it's a left to right shunt initially because of the higher pressure in the left heart system when you don't have Eisenmenger syndrome associated, but because there's so much blood shunting from the left side to the right side, you can overwhelm and overload the right side and the pulmonary vessels, and this can cause right-sided pressure to increase over time. And if right-sided pressures increase, what happens? Yeah, we talked about it before, Eisenmenger syndrome, and you get more pressure on the right side and then shunting of blood to the left, and we'll talk about that in this diagram here. So what happens here is that you start out, let's say, with the body, and the body brings unoxygenated blood back to the right atrium, and now because the right-sided pressure is greater than the left, this blood shunts over to the left side, and then now this blood is going to mix with the oxygenated blood from the lungs and cause cyanosis in the body because now this is going to the aorta and the systemic circulation. And because you have regurgitation and mixing of blood, there's going to be a lot of mixing of blood on the right side and the left side, but overall the net effect is that you're going to have hypooxygenated blood go to circulation, and this will cause many problems. So some signs and symptoms. You have heart failure due to a large left to right shunt. So you have an overload of the right heart as a result over time. And this causes problems such as dyspnea with feeding, difficulty gaining weight, and tachypnea because of failure to meet metabolic demands. So you have a large left to right shunt and the overload of the right heart in the pulmonary system. Hyperactive precordium. We've talked about how you have a hyperactive precordium if you have too much blood on the right side of the heart and in the pulmonary vessels, and that's what's going to happen here as well. You have a loud single S2 because there's so much blood on the right side, especially if you have pulmonary hypertension present. When the valve closes, there'll be a lot of pressure closing it, and it'll make a loud single sound. You also get a systolic murmur at the left upper sternal border. That's because of pulmonary blood flow across the valve. And now for diagnosis. Like always, echo is the best diagnostic test. And a chest X-ray will also show you some important findings as well, such as cardiomegaly, because there's so much blood mixing on the left and right heart. You get left and right heart enlargement as a result. Increased pulmonary vascular markings because of left or right shunt. And also you can get a prominent main pulmonary artery segment because of increased blood flow, and also if you have increased pulmonary hypertension. EKG will show left axis deviation. Actually, that should say right axis deviation. EKG will show right axis deviation, right ventricular hypertrophy, and left ventricular hypertrophy. And the treatment will be surgical repair. So key thing I want to note here is this is a normal x-ray. The only reason I'm showing it to you is you can identify where individual parts are in the x-ray so you can get better at dealing with the different diagnoses. So what we have here is the right atrium on the right side. This is the bulge on the right side of the vertebral column. The right ventricle is found underneath the vertebral column, and the left ventricle is found to the left of it over here. Left atrium is found posterior and a little bit above the left ventricle. the right pulmonary artery is found up here and up over here. You see these little like black holes in these areas. Those are the pulmonary arteries. The aortic knob is the the lump that's in the mediastinum. That'll be the aortic knob where you have the end of the arch, and the descending aorta will go back behind the heart. And you also have left pulmonary artery here as well, where's this little, you see this circular feature right here? That'll be your pulmonary artery. So these are very important to know for a normal x-ray so that you can tell what pathologic x-rays look like based on the normal findings. Now let's talk about innocent versus pathologic murmurs. So we have benign murmurs and we have pathologic murmurs. Let's find out what that means. It means you have a grade 1 or 2 out of 6 systolic murmur that decreases with standing and Valsalva. So if it decreases with standing and Valsalva, it's not associated with hypertrophic cardiomyopathy or any other serious conditions. So that's why it will be a benign innocent murmur. So it has to be grade 1 over 2, 1 or 2 out of 6, systolic, important, very important that it's systolic, and decrease with Valsalva and standing. Remember, severe conditions increase with standing and Valsalva. So the murmur decreases with decreased preload as opposed to severe conditions such as HOCM. So less preload, less murmur. It's mostly flow murmurs going on here. So here's some examples of flow murmurs. Stills murmur is very common in children. It's a low-pitched, resonant systolic murmur at the left lower sternal border, and it's usually due to flow through the left ventricular outflow tract. So I'll show you what this means when it says it's a resonance. Let's listen. So you hear that sound. You hear an extra sound that goes with the flow, and that's going to be a very resonant sound. If you listen to it, it just reverberates. Right there. Right there. You hear that resonant sound? That's the sound that you're going to hear from the Stills murmur, and that's going to be very benign. Alright, it's caused by left ventricular outflow tract flow. Pulmonary flow murmur as well, when there's excess blood flow going across the pulmonary valve, you can get an upper sternal border on the left systolic murmur. You have no associated symptoms. The more symptoms you have, the more likely the murmur is pathologic because you're actually getting symptoms. No history of sudden cardiac death in the family or congenital heart disease, and you don't need any testing in these patients. If you have all these criteria met, you don't need to test any further for problems with the heart. But now the pathologic murmurs, this is where it gets tricky and you need to start doing a workup. It's grade 3 out of 6 or greater, holosystolic or diastolic. Any holosystolic or diastolic murmur, no matter what the grade, has to be evaluated as pathologic. So even if it's 1 out of 6, you still have to work it up. Murmur worsens with standing and Valsalva. Remember, when you decrease preload and the murmur gets worse, you have to worry about a severe condition because it's not about flow anymore. You have a family history of sudden cardiac death or congenital heart disease. That's very concerning because the patient may have it as well, and associated symptoms. Always very important. And if you have any or all of these things, you should need to work up with an echocardiogram to see what exactly is going on and work it up to prevent any worse complications for our patient here. Now let's do a sample question about endocarditis prophylaxis. So, which of the following is the next best step in management? Remember, we always read the question first. Provide amoxicillin, a very common endocarditis prophylaxis. Delay the procedure to further evaluate. Proceed with the procedure. Admit the patient to the hospital for stabilization, or cancel the procedure altogether. Now let's read the question. 64-year-old woman is scheduled to have a cystoscopy and a biopsy for gross blood in her urine, and she has a history of chronic UTI with multi-drug resistant E. coli. She has a history of rheumatic fever as a child, and upon auscultation, a 3 out of 6 holosystolic murmur at the apex radiating to the axilla is heard. So this will be a mitral regurg going on here. And she had a rheumatic fever as a child, so this could be the reason for this holosystolic murmur. Otherwise, she's stable and she's consented to the procedure. The resident physician is worried about developing endocarditis and asks the attending how to manage the patient. So let's talk about what the different answer choices are here and whether we need to do any endocarditis prophylaxis. Endocarditis prophylaxis is not necessary for rheumatic fever and also is not necessary for cystoscopy with a multi-drug resistant UTI unless there's a congenital heart defect that is a previous cyanotic heart disease, or if you have any kind of severe symptoms or severe surgery that results in a prosthetic valve placement. So let's talk about A first. Do you need amoxicillin for an endocarditis prophylaxis for a patient with rheumatic fever history and a mitral regurg? Absolutely not. not necessary. And we'll talk about what the criteria are in the next slide. Delay the procedure to evaluate the heart with an echo? No, we already know what's wrong, and we don't need to worry about this right now. The procedure is more important. We're already going to go ahead with the procedure. There's not that big of a risk of developing endocarditis. Proceed with the procedure without endocarditis prophylaxis. We can hold on to that one. Admit the patient to the hospital for stabilization. Does the patient seem unstable? No, she just has a murmur, and otherwise she's stable. So you don't need to worry too much about that. Cancel procedure due to high risk of endocarditis. Remember, this procedure is just a cystoscopy and a biopsy. It's not a very severe procedure. It's not an open procedure by any means. You're just putting a scope into the bladder. So this is not very high risk for endocarditis either. So that's why you don't need to delay the procedure or cancel procedure, because it's a very mild, easy to handle procedure. So the answer will be to proceed with the procedure without endocarditis prophylaxis. Now let's talk about when we actually need endocarditis prophylaxis. Very high yield and always tested on exams, so we will definitely go over this in detail. Indication is all prosthetic heart valves. So anytime someone has a prosthetic heart valve, mechanical or bioprosthetic, they need to have endocarditis prophylaxis. Previous history of endocarditis, a major criteria here as well. Cyanotic congenital heart disease that was never repaired. That should be pretty self-explanatory. If you have cyanotic congenital heart disease, you have a high risk of endocarditis, because we talked about earlier, bacteria can go from right to left without any problems. Repaired congenital heart disease with residual shunt or regurgitation. So if you repaired it, but there's still regurgitation or shunting, this is not good and you need prophylaxis against endocarditis. First 6 months after a procedure for congenital heart defect repair, that's also very important as well. And valve regurgitation in a heart transplant patient. So a heart transplant patient without valve regurgitation does not need prophylaxis, but if you have a regurgitation on top of the transplant, you definitely do. Notice that rheumatic fever is not one of these indications, okay? You do not need to give endocarditis prophylaxis for rheumatic fever history. So in what procedures do you need to give prophylaxis? Dental procedures, such as cleaning and extractions, because there are so many bacteria in the mouth, they can enter the blood system and cause a subacute endocarditis. Respiratory tract incisions and biopsies, they also need to have prophylaxis in case any of these indications are present. So you only do these endocarditis prophylaxis for these procedures if you have any of these indications present in addition to the procedure. The only indication for endocarditis prophylaxis during GI or GU procedures is if you have a high-risk cardiac condition, as we've seen among these indications, with the GI or GU infection. But in our previous patient in the question we just did, you don't need to do a endocarditis prophylaxis because the patient does not have one of these high-risk conditions. She just has rheumatic fever. Thank you for your attention, and that is the end of our presentation.